Imagine you're in a place filled with sound. Maybe that noisy restaurant we've all been in, or perhaps just stepping outside and noticing the subtle sounds of the world around you. Hearing is this constant, intricate connection, far more complex than simply knowing how loud something is. It lets us follow conversations, orient ourselves, perceive danger, and appreciate the rich texture of our environment. But what happens when that incredibly sophisticated system doesn't work right?
Well, it's a question that really opens the door to understanding just how delicate and precise our sense of hearing is. When the system falters, the impact can range from subtle annoyance to profound isolation, affecting communication and our overall well-being. It's huge.
Absolutely. And that's precisely what we're diving into today. You, our listener, have brought us a seriously in-depth source, Chapter 34, focused entirely on disorders of hearing. This isn't a light read. This is material designed for deep understanding, like something from a foundational medical text. Really dense stuff.
It really is. It goes right to the core mechanics and the ways things can go wrong. Our mission today is to unpack this comprehensive chapter together. We want to go beyond the surface to understand how the ear works, all the different points where it can fail, the specific causes behind those failures, the detailed assessment methods used by professionals, the available treatments, and even how we can prevent some types of hearing loss. The goal is to give you a true shortcut to mastering this topic, to understand it like someone truly immersed in the field.
Exactly. We're treating this like a study session on the source, extracting every important nugget, every surprising fact, and connecting all the critical dots. Because to understand what goes wrong, we first need to appreciate the biological masterpiece that is the human ear.
You got it. Without that foundation of normal physiology, the pathology doesn't make as much sense. It's truly a marvel of biological engineering.
So let's start at the beginning of the sound wave's journey. It starts as energy in the air and has to be captured and converted into electrical signals your brain can process. Think of the ear as a complex multi-stage converter.
Yeah, and the first stages are the external and middle ear. Their primary job is to collect that sound, amplify it, and then efficiently transfer that mechanical energy inwards. Sound waves travel down the external auditory canal and cause the tympanic membrane, the eardrum, to vibrate.
That vibration then gets transferred to the chain of 3 tiny bones in the middle ear, the malleus, incisius, and stapes. These are, astonishingly, the smallest bones in your entire body.
And their function is absolutely crucial. This middle ear system, the eardrum, and those ossicles, acts as something called an impedance matching mechanism. This is a fundamental challenge the ear has to overcome. Sound travels easily through air, which has low impedance, low resistance, you could say. But the inner ear, where the magic of conversion happens, is filled with fluid, which has much higher impedance.
So it's like trying to get energy from shouting in the air into shouting underwater. Is that a fair analogy?
That's a great way to put it. Exactly. If the sound energy hit the fluid directly, almost all of it, the source says nearly 99.9%, would simply be reflected back. It wouldn't transfer effectively into the inner ear, and we wouldn't hear it properly.
That's incredible. The middle ear has to bridge this massive physical gap in efficiency.
It really does, and it's brilliant how it works. The eardrum is much larger in surface area than the footplate of the stapes, where it connects to the inner ear. This difference in area, combined with the lever action of the ossicles, works together to boost the sound energy. The source tells us it amplifies the sound energy delivered to the inner ear by almost 200 times.
Wow.
This huge boost is necessary precisely because of that impedance mismatch between air and the fluid-filled inner ear.
Wow, 200 times amplification just to get the energy across the barrier. Okay, so the sound energy is collected and boosted. Then it reaches the inner ear, specifically the cochlear. This is where the mechanical energy finally gets turned into electrical signals. The brain can understand a process called mechanotransduction.
Right. The cochlea is that beautifully shaped, fluid-filled structure, often described as snail-shaped. Inside you have the basilar membrane, and sitting on that membrane is the organ of Corti, which contains the critical sensory cells, the hair cells.
The famous hair cells. Okay, what makes them so special? What's their deal?
They are the primary mechanoreceptors of hearing. There are 2 types, inner hair cells and outer hair cells. They take the motion caused by the traveling waves in the cochlear fluid and convert it into a neural signal. There's a significant difference in their numbers and how they're wired up. You have about 3,500 inner hair cells, but around 20,000 outer hair cells, so like a 6-to-1 ratio roughly. And importantly, the inner hair cells are where most of the afferent nerve fibers connect the ones sending signals to your brain. The outer hair cells are mostly connected to efferent nerve fiber signals coming from the brain.
That difference in wiring is fascinating. So the brain is talking back to the outer hair cells.
In a way, yes, it modulates their function. But let's talk about the conversion first. How do these hair cells perform this magical conversion from motion to electricity? It's a stunning piece of biological machinery. The tiny hair-like projections on the hair cells are called stereocilia. They're arranged in rows of different heights. They are connected to the tectorial membrane above them, or at least the taller ones often are. When the basilar membrane moves up and down due to the sound wave, it causes these stereocilia to bend, to pivot at their base. And this bending stretches tiny, incredibly important filaments connecting the tips of the stereocilia, called tip links.
Tip links, like tiny trapdoors being pulled open by the bending.
Exactly that. Stretching those tip links mechanically pulls open ion channels located at the tips of the stereocilia. This allows ions, specifically potassium ions, which are abundant in the surrounding fluid, to flow rapidly into the hair cell. This influx of positive charge depolarizes the hair cell, causes a voltage change, leading to the release of neurotransmitters at its base, which then excite the fibers of the auditory nerve. That's the core of mechanotransduction physical movement, opening ion channels to create an electrical signal. It's incredibly fast and precise.
It's a delicate dance of structure and chemistry, really intricate. And what about those many outer hair cells with the different wiring? What's their unique contribution? Why so many?
This is where the cochlea's exquisite sensitivity comes from. The outer hair cells are not just passive receivers, they are actively modal. They can actually change their length, contract, and expand in response to electrical signals from the brain and the mechanical stimulation they receive. It's called electromotility.
They move themselves.
Yes. This active motility physically alters the micromechanics of the basilar membrane locally. It enhances the movement, particularly for low-level sounds, and sharpens the tuning. It essentially acts as a cochlear amplifier, boosting the vibration right where it needs to be boosted for the inner hair cells to detect faint sounds. This active process is what allows us to hear incredibly quiet sounds and discriminate between frequencies with such fine detail. It's amazing.
An active amplifier built right into the ear. That's truly next-level engineering.
And how does the cochlea sort out different pitches, like high notes versus low notes?
The basilar membrane itself acts like a frequency analyzer. It's narrower and stiffer near the base of the cochlea, where it connects to the middle ear, and wider and more flexible towards the apex, the inner tip of the spiral. Because of these physical properties, different sound frequencies cause the maximum vibration of the basilar membrane at different locations along its length. High frequencies cause the biggest displacement near the stiff base, while low frequencies travel further into the coil, causing maximum displacement closer to the flexible apex. So it's like a piano keyboard unrolled along the cochlea.
That's a good analogy. This organized mapping of frequencies to locations is called tonotopy, and it's remarkably preserved throughout the entire auditory pathway, right up to the brain.
So the brain figures out the pitch based on which nerve fibers are firing, basically where along the nerve the signal is coming from.
Precisely. That's the primary mechanism for pitch perception, especially at higher frequencies. The auditory nerve fibers also encode other aspects of sound. They vary their firing rate to encode intensity or loudness. And at low frequencies, they can fire in sync with the sound wave itself, a process called phase locking, which helps the brain encode the timing information in sound, crucial for things like localization and complex sound perception.
Okay, so this complex neural code travels up from the auditory nerve. Where does it go next?
It travels up through a series of relay stations in the brainstem, first the cochlear nuclei, then the superior olivary complex, which is important for comparing inputs from both ears for sound localization, then up via the lateral lemniscus to the inferior colliculus, then to the medial geniculate body of the thalamus, before finally reaching the auditory cortex in the temporal lobe of the brain.
That's a lot of processing stations. It's not just a straight wire.
Not at all. Each station performs further processing, refining the signal, integrating information from both ears. And that frequency specificity, the tonotopy, is maintained all the way up.
Is there anything else fascinating about how the brain handles sound, particularly mentioned in the source?
Yes. This is where it gets truly interesting in terms of higher-level processing. While the initial signal might seem to follow symmetric pathways, there's strong evidence that the brain processes certain sounds, particularly speech, asymmetrically. We see this in dichotic listening tasks where you play different sounds to each ear simultaneously. Most people show a right ear advantage for rapid sequential sounds like consonant vowel syllables or words. They report what they heard in the right ear more accurately.
The right ear is better at picking up details in speech. Why would that be? Is it about the ear itself?
It's not the ear itself, but how the brain is wired. It's linked to the lateralization of function in the brain's auditory cortex. The primary auditory pathway from the right ear projects most strongly to the left hemisphere's auditory cortex, and vice versa. The source notes that the left auditory cortex is generally more specialized for processing the fine acoustic details, the rapid temporal changes necessary for speech recognition and production. Meanwhile, the right hemisphere seems more involved in processing the slower, more holistic aspects of sound, like the emotional tone, prosody, or musical melody.
So the left brain handles the words, the right brain handles the music or emotion, roughly speaking.
That's a common way to think about it, though it's a bit simplified. This left hemisphere dominance for speech is remarkably consistent, seen in 95–98% of right-handed individuals, and even a majority, 70–80%, of left-handed individuals.
Why might the brain do this? Any ideas?
Well, specialization often leads to efficiency. Having dedicated circuits for different types of complex auditory analysis might just be a more efficient way to process the constant stream of sound information we encounter.
It does feel like the brain is incredibly efficient, dividing labor where it makes sense. So that's the incredible system when it's working perfectly. A true masterpiece. But this chapter, our source for today, focuses on what happens when it doesn't.
Right. And the source categorizes hearing disorders based on where the problem lies in that journey we just traced. The two main types are conductive hearing loss and sensorineural hearing loss, or SNHL. And of course, you can also have mixed hearing loss, which is simply a combination of both.
Okay, let's start with conductive hearing loss. Where is the issue located here? What's the basic idea?
The core problem in conductive loss is an impedance or blockage that prevents sound waves from effectively reaching the inner ear. The sound is simply dampened or blocked on its way in. So the anatomy affected is anything in the external ear, the auricle or pinna, the external auditory canal, or the middle ear, the eardrum, and the ossicles.
Okay, so it's a mechanical problem before the inner ear. What are some of the most common causes, the source details? Seems like a lot could go wrong there.
Many things can obstruct that path. The most basic are obstructions in the ear canal itself. Things like cerumen, which is just earwax buildup or debris, or even foreign bodies someone might put in their ear. Then there are issues with the canal's structure, like swelling from infection, otitis externa, or more seriously, a complete congenital closure of the canal, called atresia or neoplasms, which are growths in the canal.
Okay, wax, infections, blockages. What about the eardrum?
Problems of the eardrum, the tympanic membrane, are also common causes of conductive loss, specifically perforations, or holes in the eardrum. These can happen from trauma, like a Q-tip injury or a slap to the ear, or from infections like acute otitis media, where pressure builds up and bursts the drum, or from chronic otitis media. The source notes that while small perforations can sometimes heal on their own, larger or persistent ones often require surgical repair. A procedure called tympanoplasty is used to patch the hole, and it has a high success rate, over 90%.
Good success rate for fixing holes. And if the eardrum is fine, what about those tiny bones it's connected to, the ossicles?
Yes, the ossicular chain can be the source of the problem too. It can be disrupted, the connections broken, often due to necrosis, where the bone tissue dies, maybe from severe trauma or chronic infection. Another key cause affecting the ossicles is otosclerosis. We'll probably talk more about that one, but essentially a stapes bone, the final bone in the chain, gets fixed in place and can't vibrate properly to transmit sound to the inner ear.
Stapes get stuck. Got it. What else in the middle ear?
Well, the middle ear space itself can be the problem. Fluid accumulating behind the eardrum, known as serous otitis media, SOM, or middle ear effusion, is very common, especially in kids. Scarring from past infections, or again, neoplasms growing in the middle ear space can also impede the ossicles movement.
And I know eustachian tube dysfunction is notorious for causing ear problems, especially that fluid buildup.
It's an extremely common underlying cause of middle ear problems and conductive loss in adults and children. When the eustachian tube, which connects the middle ear to the back of the nose and throat, doesn't open properly to equalize pressure, it creates negative pressure in the middle ear. This can pull the eardrum inward, making it stiff, or it can cause fluid to be drawn from the surrounding tissues into the middle ear space, leading to that serous otitis media. The source even mentions balloon dilation of the eustachian tube as a newer treatment option for chronic obstruction, trying to physically open it up.
That's quite a list of potential mechanical problems. Are there a couple of standout causes from the source that warrant maybe a bit more detail, things people should really know about?
Definitely. Cholesteatoma is one that's really important to understand because it can be destructive. The source describes it as a benign, meaning non-cancerous but locally destructive tumor, or, more accurately, a cyst made of stratified squamous epithelium. That's basically skin cells growing in the wrong place, usually starting in a retraction pocket of the eardrum and growing into the middle ear or the mastoid bone behind the ear.
Skin growing where it shouldn't be and it's destructive. That sounds quite serious. How is it usually spotted? What are the signs?
It often arises from severe chronic eustachian tube dysfunction, creating those retraction pockets. As it grows, it sheds skin layers, creating this debris-filled sac that can slowly erode the delicate bones of the middle ear, including the ossicles, and even bones surrounding the inner ear or facial nerve. The source gives clear diagnostic clues. A chronically draining ear, often foul-smelling, that doesn't clear up with antibiotics. Seeing cheesy white squamous debris during an otoscopic exam, sometimes an oral polyp, a fleshy growth, is visible. And of course, a conductive hearing loss, often because it's eroded the ossicles. Temporal bone CT scans are crucial as they can show the characteristic bony erosion caused by the cholesteatoma. The source stresses that surgery is absolutely necessary to remove it completely and prevent further damage.
Okay, so persistent drainage plus conductive loss equals think cholesteatoma. Get it checked out. Got it. What about otosclerosis again? We touched on the stape fixation. Can we elaborate?
Right, otosclerosis is a primary bone disease of the temporal bone. Abnormal bone remodeling occurs, typically affecting the bone around the oval window where the stape's footplate sits. This new spongy bone growth gradually hardens or sclerotizes and fixes the stapes in place, preventing it from vibrating. This usually starts as a progressive, low-frequency conductive hearing loss, often beginning in both ears, though maybe asymmetrically.
And its cause?
It has a definite genetic link. It's typically inherited in an autosomal dominant pattern, but with incomplete penetrance, meaning not everyone who inherits the gene develops the condition. It can also be associated with osteogenesis imperfecta, the brittle bone disease. It commonly starts to cause symptoms in the late teens to 40s. And interestingly, the source specifically notes that in women, the hearing loss can be accelerated during pregnancy, likely due to hormonal changes.
Accelerated by pregnancy, that's a specific detail I wouldn't have expected. That's fascinating.
Nor I. It's quite specific. Treatment options include hearing aids to simply amplify the sound past the blockage or surgery. Specifically, a stapedectomy or stapedotomy, which involves removing part or all of the fixed stapes and replacing it with a tiny prosthesis. This surgery is highly successful, the source says over 95%, in restoring hearing by reestablishing that mechanical link to the inner ear. One other point the source makes is that if the otosclerotic process spreads beyond the oval window to affect the cochlea itself, it can then cause a sensorineural or mixed hearing loss component as well.
Okay, that makes sense. And then there are the third window disorders. That sounds very unique, almost mysterious. What's that about?
They really are quite fascinating and relatively recently understood. The source explains that normally the inner ear interfaces with the middle ear through two openings covered by membranes, the oval window, where the stape sits, and the round window. These allow fluid movement within the cochlea when sound enters. In third window disorders, there's an abnormal third opening, a dehiscence or thinning, in the dense bony capsule surrounding the inner ear. This creates an abnormal path for sound energy or pressure to escape or enter the inner ear.
Like the energy is leaking out somewhere it shouldn't, or pressure changes are getting in.
Exactly. It dissipates the acoustic energy that should be focused on moving the inner ear fluids properly, resulting in a conductive hearing loss. Or it allows pressure changes from the middle ear or even intracranial space to abnormally stimulate the inner ear fluids, causing more symptoms. The classic example is superior semicircular canal dehiscence, SSCD. This is caused by erosion or absence of the bone overlying the topmost balance canal.
And the symptoms are pretty wild.
They are remarkable and distinct. Patients often have a conductive hearing loss that can mimic otosclerosis. But crucially, they also experience vestibular symptoms like vertigo or oscillopsia, visual bouncing, triggered by loud sounds, that's the Tullio phenomenon, or by pressure changes like straining, coughing, Valsalva maneuvers, or even just pressing on the tragus, the little flap in front of the ear canal. Some patients also report autophony, hearing internal body sounds abnormally loudly, like their own eye movements, chewing, footsteps, or even their own voice echoing internally.
Hearing your own eye movements, that sounds truly bizarre and must be incredibly distracting. Are there other ways a third window can form besides the superior canal?
Yes. The source mentions other possibilities. For instance, a high-riding or enlarged jugular bulb, the big vein below the ear, or a diverticulum, an outpoaching from it, can erode the bone near the vestibular aqueduct or posterior semicircular canal. Certain congenital inner ear malformations like dysplasia, abnormal formation of the lateral semicircular canal, an enlarged vestibular aqueduct, or an incomplete partition between inner ear compartments, sometimes seen in conditions like Stapes gusher syndrome where there's a fluid leak during Stapes surgery, can also effectively create a third window.
How are these third window problems diagnosed if they can mimic other things like otosclerosis?
The unique symptoms are a big clue, but testing helps confirm it. The source points to a characteristically low activation threshold on the vestibular evoked myogenic potential, VEMP test, meaning the vestibular system responds to sound at much lower levels than normal. That's a key indicator. And importantly, seeing the actual bony defect, the dehiscence, on a high-resolution temporal bone CT scan is essential for diagnosis. This often requires specific imaging reconstructions, like postural views, designed to look right along the plane of the superior canal.
And treatment.
Surgical repair of the dehiscence, basically plugging or capping the hole in the bone, is an option, primarily considered for patients with disabling vertigo or balance symptoms that don't respond to conservative measures.
Okay, so that wraps up the conductive issues, problems blocking or disrupting the sound transmission before the inner ear. Now let's move on to sensorineural hearing loss, SNHL. Where is the problem located in this case?
With SNHL, the problem lies deeper, within the inner ear itself, specifically damage to the cochlea, particularly the delicate hair cells, or along the pathway transmitting the electrical signal from the inner ear to the brain. That includes the auditory nerve, the eighth cranial nerve, or the central auditory pathways within the brainstem and brain. So the issue isn't primarily sound getting in. It's about the conversion of sound into electrical signals, or the transmission and processing of those signals once they're generated.
So the system that turns the mechanical energy into electrical signals is damaged, or the wire to the brain is faulty, or the processing centers are affected. What are the key causes affecting the inner ear or the auditory neurons directly?
The source lists quite a few important ones. Damage from exposure to excessive noise is a huge one. Viral infections can affect the inner ear. Certain medications are known to be ototoxic, meaning harmful to the ear. Temporal bone fractures can directly injure the inner ear structures. Meningitis can cause inflammation that damages the cochlea or nerve. Otosclerosis, if it extends into the cochlea, can cause SNHL. Meniere's disease involves inner ear fluid imbalance. And then there's the most common cause in adults, aging, which leads to presbycusis. Congenital malformations of the inner ear can be present from birth. And finally, genetic predispositions can make someone more susceptible, either causing hearing loss directly or increasing vulnerability to other factors like noise or drugs.
Noise exposure is something many people encounter in their daily lives, at work, or recreationally. Let's talk more about that.
It's a major and crucially preventable cause of SNHL, leading to noise-induced hearing loss, or NIHL. Acute exposure to extremely loud sounds, like an explosion or a gunshot near the ear, can cause immediate, sometimes temporary, sometimes permanent, hearing threshold shifts. This results from direct mechanical injury to the hair cells or even their death. Chronic, repeated exposure to sounds that aren't necessarily painful but are still loud enough over time causes gradual, cumulative damage.
And there's a characteristic pattern on the hearing test for NIHL.
Yes, a classic sign on an audiogram for permanent NIHL is a specific dip or notch in hearing sensitivity, usually centered around 3,000 to 4,000 hertz, sometimes extending to 6,000 hertz. Hearing at lower and much higher frequencies might still be relatively normal, at least initially.
A notch just at that specific frequency range. Why is that frequency particularly vulnerable to noise damage?
It's thought to be related to a combination of factors. The natural acoustic resonance of the external ear canal tends to amplify sounds in the 2-4 kilohertz range. Also, the mechanics of the middle ear transmission might focus energy efficiently onto the part of the cochlea responsible for those frequencies. And maybe that specific region of the cochlea is just metabolically more vulnerable or has less robust repair mechanisms. It makes those hair cells and their synapses particularly susceptible to damage from intense sounds over time.
That makes sense. And the source mentions a newer concept, hidden hearing loss. That sounds important, but, well, hidden, subtle.
This is where it gets really interesting and highlights the increasing complexity of how we understand hearing loss. Hidden hearing loss refers to a situation where a person has normal or near normal result on standard pure tone audiometry, the test that measures the softest sound you can hear at different frequencies, but they still report significant difficulty hearing clearly, especially understanding speech in noisy environments like restaurants or parties.
So the basic hearing test looks okay, but they still struggle in real life.
Exactly. The source explains that while traditional NIHL often involves the death of hair cells, particularly outer hair cells, which would show up on the audiogram, hidden hearing loss is thought to involve damage or loss of the synapses connecting the inner hair cells to the auditory nerve fibers, or perhaps damage to the nerve fibers themselves. The inner hair cells might still be present and functioning to some extent, allowing detection of quiet tones, but the transmission of detailed information, especially in noisy conditions, is impaired.
So the sensor might be fine, but its connection to the wire is weak or broken, leading to poor signal fidelity.
That's a good way to conceptualize it. The signal is generated, but it's not transmitted efficiently or robustly enough to the brain for clear perception, particularly for complex sounds or when the system is stressed by background noise. The source strongly emphasizes that avoiding acoustic trauma using earplugs or earmuffs in loud environments is crucial for preventing both traditional NIHL and potentially this hidden hearing loss. Given how noisy our modern world is, prevention is absolutely key here. We'll come back to prevention specifics later.
Definitely. What's the most common cause of SNHL overall in adults, according to the source?
That would undoubtedly be presbycusis, which is simply age-associated hearing loss. The source states that it's estimated to affect over half of adults in the U.S. aged 75 or older. It's incredibly prevalent.
Over 50% of people over 75. Wow, that's a huge public health issue. How does it typically progress? What does it look like on a hearing test?
It's usually a symmetric loss, meaning it affects both ears fairly equally. It typically starts with the higher frequencies and gradually slopes downwards to affect lower frequencies as it progresses over years or decades. The audiogram often shows a gentle to sharply sloping pattern, worse in the high pitches.
And what are the key symptoms people notice beyond just things sounding quieter? Is it just about volume?
No, and this is critical. The source highlights that the primary symptom, especially early on, is often a significant loss in clarity, not just loudness. Patients struggle to distinguish between similar sounding consonants, like ep, ep, making speech sound muffled or distorted. They report difficulty understanding speech, particularly when there's background noise, the classic complaint of not being able to follow conversations in restaurants or social gatherings. They may also experience recruitment, that abnormal growth of loudness where quiet sounds are inaudible, but slightly louder sounds quickly become uncomfortably loud or distorted.
Right, that loss of the ear's natural dynamic range compression we talked about with SNHL.
Exactly. And the source makes a really powerful point about the broader impact of untreated presbycusis. It's not just an inconvenience. It's clearly linked in research to an increased risk of developing cognitive impairment and dementia, and a faster rate of cognitive decline in those who already have issues. It's also linked to an increased risk of falls, social isolation, depression, a diminished overall quality of life, and even increased morbidity and mortality.
That's a stark connection, hearing loss, impacting brain health, safety, and longevity. It really raises an important question. Given these significant health consequences, why is age-related hearing loss so often ignored, dismissed as just getting older, or undertreated in healthcare?
It's a critical question. There's growing awareness, but historically, yes, it's been underappreciated and underaddressed, compared to other age-related conditions like vision loss or arthritis.
So how is presbycusis managed, given its impact?
The primary treatment for mild to severe SNHL from presbycusis and other causes is amplification with hearing aids. The source notes the significant advancements in digital hearing aid technology. They are much smaller, some are nearly invisible, fitting deep in the canal. They have sophisticated features like multiple microphones and directional processing algorithms designed to help improve the signal-to-noise ratio, focusing on speech coming from the front and reducing background noise, which can make understanding speech easier in some challenging situations.
But you mentioned earlier they can't fully restore clarity, especially if the damage is significant.
That's the fundamental limitation with SNHL. Hearing aids amplify sound very effectively, but they can't fully repair the damaged signal processing that occurs in a damaged cochlea or along the auditory nerve pathway. If the underlying biological system isn't coding the sound clearly, just making the distorted signal louder doesn't fully restore clarity. The source specifically notes that amplification may have limited benefit if word recognition scores drop below about 50%. For those individuals, when hearing aids are insufficient, cochlear implants become the next treatment option to consider.
That makes sense. But even with their limitations, hearing aids seem beneficial.
Oh, absolutely. For the vast majority of people with presbycusis, hearing aids provide significant benefit in improving communication and reducing listening effort. And importantly, the source highlights research showing that hearing aid use is associated with a reduced risk of cognitive decline and a lower risk of falls in older adults. That's a powerful argument for intervention, not just for hearing's sake, but for overall health.
That's a really significant finding, but cost can be a barrier to getting hearing aids right.
It certainly can be. The source quotes an average cost of around $2,300 US per aid back when it was written, and bilateral fitting, an aid for each ear, is often recommended for the best results. So it can be a substantial out-of-pocket expense for many, as it's often not covered by insurance or Medicare.
Yeah, that's a lot. However, you mentioned something new and potentially game-changing.
Yes, here's where it gets really interesting and potentially disruptive for the future of hearing healthcare. The relatively new FDA-approved category of over-the-counter OTC hearing aids.
OTC hearing aids available directly to consumers without a prescription or needing to see an audiologist first.
Exactly. For adults with perceived mild to moderate hearing loss. The source speculates, and I think this is widely believed, that this could fundamentally change hearing healthcare delivery. The hope is that it will reduce costs through direct sales and increased competition, spur innovation in user-friendly devices, and ultimately make amplification much more accessible to the millions of people who have hearing loss but haven't sought traditional hearing aids due to cost, access, or stigma. It's still early days, but it's a major shift.
That could truly open up access for many people. Let's shift gears slightly and discuss another specific SNHL cause mentioned, Meniere's disease. It seems to involve more than just hearing loss.
It certainly does. Meniere's disease is a disorder of the inner ear characterized by a very specific pattern of symptoms, often referred to as a tetrad. These are 1. Episodic rotational vertigo, sudden attacks of intense spinning sensation, which the source states is essential for the diagnosis. 2. Fluctuating sensorineural hearing loss. The hearing loss often gets worse during or before an attack and may recover somewhat afterwards, at least early in the disease. 3. Tinnitus, ringing or roaring sound in the affected ear, often also fluctuating. And 4. Oral fullness, a feeling of pressure or blockage in the ear. If someone has the hearing loss, tinnitus, and fullness without the definite episodes of vertigo, the diagnosis is more likely cochlear hydrops, considered a related but distinct condition. The symptoms tend to worsen significantly during the acute attacks of Meniere's.
So it's not a constant state, but comes in attacks with this cluster of symptoms.
Yes, the episodic nature of the vertigo is really key to the classic definition. The source notes the annual incidence is somewhere between 0.5 and 7.5 per 1,000 people, so it's not extremely common, but not rare either. Onset is typically in the 5th decade of life, so 40s or 50s, but it can affect adults at any age.
What's actually happening inside the inner ear during these attacks? What's the underlying pathology?
Histologically, meaning when you look at the tissue under a microscope, the hallmark finding described in the source is endolymphatic hydrops. This is a distension or swelling of the fluid-filled sacs within the inner ear's endolymphatic system, caused by an imbalance between the production and absorption of endolymph fluid. It's thought that this increased fluid pressure distorts the delicate membranes within the cochlea and vestibular system, leading to dysfunction and, over time, potentially degeneration of the hair cells in both the hearing and balance parts of the inner ear.
And what causes this fluid imbalance, this hydrops?
Well, in many cases, the exact cause is unknown. That's termed idiopathic Meniere's disease, which is the largest category. However, hydrops can also be secondary to other problems that affect the endolymphatic sac, which is thought to be responsible for fluid resorption. These can include damage from viral infections, head trauma, autoimmune disorders, inflammatory conditions, or even certain rare tumors like endolymphatic sac tumors, which the source notes can sometimes be linked to the genetic condition von Hippel-Lindau disease.
What's the usual pattern of hearing loss seen in Meniere's?
While it can be variable, the source says the characteristic pattern, especially early on, is a low-frequency SNHL, often primarily affecting one ear, though it can become bilateral over time in some patients. However, any pattern of SNHL is possible as the disease progresses.
How is it diagnosed aside from the classic symptoms?
The diagnosis is primarily clinical, based on the history of distinct episodes meeting specific criteria. Testing helps support the diagnosis and rule out other conditions. An audiogram will show the SNHL, which might fluctuate between tests. Vestibular testing, like VNG, video nystagmography, might show reduced function in the affected ear's balance system. The course also mentions that an abnormal VEMP test, sometimes showing abnormalities even in the contralateral opposite ear, can be suggestive. An MRI is usually done, mainly to rule out other causes of similar symptoms, particularly retrocochlear pathology like tumors, for example, vestibular schwannoma, or demyelination, e.g. MS.
And treatment. How is Meniere's managed?
Management starts conservatively. Dietary changes are often recommended, specifically a low-salt diet, and sometimes reducing caffeine and alcohol intake, as these can influence fluid balance. Diuretics, water pills, may be prescribed to try and reduce overall fluid retention. For acute vertigo attacks, medications like meclizine or benzodiazepines can help suppress the symptoms. If attacks are frequent or severe, short courses of oral steroids or even steroid injections directly into the middle ear, intratympanic steroids, might be tried to reduce inflammation. For patients with persistent, disabling vertigo that doesn't respond to medical therapy, more invasive treatments are considered. These can include injections of gentamicin, an ototoxic antibiotic, into the middle ear to selectively damage the vestibular hair cells, or surgical procedures like endolymphatic sac decompression, controversial efficacy, labyrinthectomy, destroying the inner ear balance function entirely, sacrificing hearing, or vestibular nerve section, cutting the balance nerve. The source notes that the more ablative procedures, labyrinthectomy and vestibular nerve section, are highly effective, over 90%, for abolishing the debilitating rotatory vertigo attacks.
That's good for the vertigo, but what about the other symptoms?
This is a crucial point the source makes. Unfortunately, there is currently no effective therapy that reliably halts the progression of hearing loss or consistently eliminates the tinnitus or oral fullness associated with Meniere's disease. Treatment focuses primarily on controlling the vertigo. This really raises an important question. Why are the sensory symptoms of this disease, the hearing loss and tinnitus, so much harder to treat effectively than the vertigo component? It highlights the complexity of inner ear pathology.
That's a significant limitation and must be frustrating for patients. You also mentioned earlier that SNHL can be caused by problems after the inner ear in the central auditory pathways?
Yes, absolutely. Damage or disease affecting the auditory nerve itself, or the complex pathways it connects to within the brainstem and auditory cortex, can also result in SNHL. The source lists various potential causes here: neoplastic tumors, vascular, like stroke, demyelinating diseases like multiple sclerosis, infectious processes, degenerative conditions, or traumatic brain injury affecting these pathways.
Is there a key characteristic of SNHL caused by these central problems compared to cochlear SNHL?
Yes. A hallmark often noted is that the reduction in clarity and speech comprehension is frequently disproportionately worse than what you might expect based solely on the loss shown in the pure tone thresholds. The basic ability to detect quiet sounds might be relatively preserved, but the ability to process complex sounds like speech, especially in noise, is severely impaired.
So it's like the signal is getting through at a basic level, but it gets corrupted or scrambled on the way to or within the brain's processing centers.
Precisely. The timing and integration of the neural signals are disrupted. Testing might show results consistent with what's sometimes called auditory neuropathy spectrum disorder, ANSD. In some forms of ANSD, you might see normal otoacoustic emissions, OAEs, which indicate healthy outer hair cell function in the cochlea, but abnormal auditory brainstem response, ABR tests, reflecting poor synchronization or conduction along the auditory nerve or brainstem pathways. The problem is with the signal transmission or central processing, not necessarily the initial sound detection in the cochlea.
What are some specific examples of these central auditory pathway causes?
The source gives several examples. Certain hereditary sensorimotor neuropathies, like Charcot-Marie-Tooth disease, and inherited disorders affecting myelin, the insulation around nerve fibers, can impact the auditory nerve. Tumors in the cerebellopontine angle, CPA, the space near the brainstem where the auditory and facial nerves run, are a classic cause. Vestibular schwannomas, acoustic neuromas, which are benign tumors arising from the Schwann cells insulating the vestibular nerve, are the most common. Meningiomas are another type of tumor found there. These CPA tumors typically cause a slowly progressive asymmetric SNHL, worse in one ear, often accompanied by tinnitus and imbalance. As we mentioned, a key feature is often significantly poorer speech understanding than predicted by a pure tone audiogram. As these tumors grow larger, they can compress adjacent cranial nerves, leading to symptoms like facial weakness or numbness, affecting the facial and trigeminal nerves.
So asymmetric SNHL with bad speech scores really flags a possible tumor.
It's definitely a red flag that warrants investigation, usually with an MRI. Multiple sclerosis, MS, is another cause. The source notes MS can cause acute unilateral or bilateral hearing loss, sometimes fluctuating. Patients might experience significant fluctuations in speech understanding, even if their pure tone thresholds remain relatively stable, reflecting the variable nature of demyelination in the central pathways. Stroke is another possibility. An isolated labyrinthine infarction, usually due to blockage of the anterior inferior cerebellar artery, AICA, which supplies the inner ear and parts of the brainstem, can cause sudden, profound hearing loss, often accompanied by severe vertigo. This can sometimes be a warning sign of a larger impending stroke in the posterior circulation, like the basilar artery. And the source also mentions that HIV infection can affect both the peripheral and central auditory systems through various mechanisms.
It's really important to realize that hearing loss, especially sudden or asymmetric loss, or loss with neurological symptoms, can be a sign of serious underlying neurological issues that need prompt evaluation. Okay, let's quickly revisit mixed hearing loss before moving on.
Right. Mixed hearing loss is straightforward in concept. It's simply the presence of both a conductive hearing loss component and a sensorineural hearing loss component in the same ear.
So a combination of blockage or mechanical problem in the outer middle ear and damage in the inner ear or auditory pathway.
Exactly. There's an air bone gap on the audiogram, indicating the conductive part, and the bone conduction threshold themselves are also elevated, indicating the SNHL part. The source notes it can occur in various conditions. For example, otosclerosis that has fixed the stapes, conductive, but has also spread to damage the cochlea, sensorineural. Certain types of head trauma might damage both middle and inner ear structures. Chronic otitis media or cholesteatoma can erode ossicles, conductive, and sometimes toxins from the infection can seep into the inner ear, causing SNHL. Middle ear tumors could invade both areas, and some congenital inner ear malformations might involve abnormalities in both the middle and inner ear.
Got it. And trauma, like temporal bone fractures, seems like it could cause any type of loss depending on exactly where the fracture line runs.
Precisely. The temporal bone houses the entire hearing and balance apparatus, so fractures in this area are serious. The source notes that temporal bone fractures can cause conductive loss if the fracture ruptures the eardrum or disrupts the ossicular chain. Sensorineural loss if the fracture line extends to the cochlea or damages the auditory nerve. This often results in profound permanent hearing loss and severe vertigo if the vestibular system is also involved. Or mixed loss if both middle and inner ear structures are damaged.
Are there specific complications from temporal bone fractures mentioned in the source that are important to be aware of?
Yes, a couple of key ones. One is the possibility of a paralymphatic fistula. This is a tear in the membranes of the oval or round window, causing leakage of inner ear fluid, paralymph, into the middle ear space. This can cause fluctuating hearing loss and vertigo, and typically requires surgical exploration and patching to repair the leak. Another significant potential complication is facial nerve injury, as the facial nerve runs a long course through the temporal bone very close to the ear structures. Facial paralysis can occur immediately or be delayed due to swelling.
Imaging must be critical after head trauma with hearing loss or dizziness.
Absolutely. The source states that high-resolution CT scanning of the temporal bone is the best imaging modality for assessing the fracture itself, its location and extent, and for evaluating the ear canal, the integrity of the ossicular chain, and any bony involvement of the inner ear labyrinth. MRI might be added if there's concern about injury to the auditory nerve, brainstem, or other intracranial soft tissue structures. The source also briefly mentions that cerebrospinal fluid, CSF, leaks can occur if the fracture extends through the dura mater, the lining of the brain, often presenting as clear fluid draining from the ear, otorrhea, or nose, rhinorrhea. These usually resolve on their own, but the value of prophylactic antibiotics to prevent meningitis in these cases is considered uncertain.
Okay, we've covered the types and major causes of hearing loss itself. What about tinnitus, that perception of sound when none is actually present? It often goes hand in hand with hearing loss.
It does. Tinnitus is a very common symptom, subjectively described by patients as buzzing, roaring, hissing, clicking, or ringing sounds. The source emphasizes that it's very frequently associated with either conductive or sensorineural hearing loss. Although the exact pathophysiology, how the brain generates this phantom sound, isn't fully understood, is thought to often relate to the brain trying to compensate for reduced input from the damaged auditory periphery, leading to abnormal neural activity in the central auditory pathways that is interpreted as sound.
So the cause of the tinnitus often mirrors the cause of the hearing loss?
Generally, yes. If you have NIHL, you might have high-pitched ringing. If you have Meniere's, the tinnitus might fluctuate with the other symptoms. Importantly, the source points out that tinnitus can sometimes be the very first symptom of a more serious underlying condition, particularly something like a vestibular schwannoma, even before significant hearing loss is noticed. So, new onset tinnitus, especially if it's unilateral, warrants evaluation.
Is there a specific type of tinnitus that should raise particular concern and requires urgent evaluation?
Yes. Here's where it gets really important from a diagnostic perspective, as highlighted in the source. That's pulsatile tinnitus. This is tinnitus that is perceived as a pulsing or rushing sound that is synchronous with the patient's own heartbeat.
You can hear your pulse in your ear.
Exactly. This specific type of tinnitus absolutely requires thorough evaluation because it could be a symptom of underlying vascular abnormalities in the head or neck. The source lists potential causes such as vascular tumors like glomus jugulare or glomus tympanicum, arterial aneurysms, arteriovenous malformations or fistulas, or significant stenotic lesions narrowing in the carotid arteries or other vessels causing turbulent blood flow near the ear. It can also sometimes occur with non-vascular conditions like middle ear fluid, SOM, or those inner ear dehiscence syndromes like superior semicircular canal dehiscence, where the pulse pressure might be transmitted more easily to the inner ear.
So, if the ringing or noise is pulsing in time with your pulse, definitely see a doctor promptly.
Absolutely. Needs investigation. Interestingly, the source notes that the most common identifiable cause associated with pulsatile tinnitus is actually an abnormality of the jugular bulb, the large vein situated just below the middle ear, such as it being unusually large, high riding, or having a diverticulum outpouching that brings turbulent venous blood flow close to the ear structures. If extensive imaging, like MRI, CT angiography, doesn't reveal a specific treatable vascular pathology, the pulsatile tinnitus is often attributed simply to the patient's perception of normal, perhaps slightly turbulent venous blood flow near the ear.
Okay. And how is tinnitus, the non-pulsatile kind, generally managed? You mentioned no real cure.
Right. Management focuses primarily on minimizing the patient's appreciation or awareness of the tinnitus and reducing the distress it causes. Lifestyle changes can sometimes help, such as minimizing caffeine and NSAID intake, like ibuprofen, as these can sometimes exacerbate tinnitus in some people. Stress reduction techniques are often recommended, as stress reliably makes tinnitus seem worse. Devices can be very helpful. Simple masking with background sound, like quiet music, a fan, or a white noise generator, can help make the tinnitus less noticeable, especially in quiet environments or when trying to sleep. Hearing aids are often beneficial for people with tinnitus and underlying hearing loss. By amplifying external sounds, they can effectively mask the tinnitus or reduce the contrast between the tinnitus and the ambient sound environment. Specific tinnitus maskers or sound generators are also available. These devices produce a more pleasant or neutral sound, sometimes tailored to the patient's tinnitus frequency, designed to make the tinnitus less intrusive. Some evidence suggests they might even provide residual inhibition, where the tinnitus remains suppressed for a period even after the masker is turned off. The source also adds that while no medication reliably cures tinnitus, antidepressants can sometimes be helpful for patients who experience significant anxiety or depression related to their tinnitus, helping them cope better with the symptom.
Okay, that makes sense. Management is key. Let's transition now to hereditary hearing impairment, HHI. Genetics clearly plays a huge role, particularly in childhood hearing loss.
A major factor, yes. The source states that it's estimated that over half of all significant hearing loss in children is hereditary in origin. And importantly, hereditary forms can also manifest later in life, not just at birth. HHI is broadly classified into two main types based on whether other body systems are involved. Non-syndromic HHI, where hearing loss is the only apparent clinical finding, and syndromic HHI, where the hearing loss occurs as part of a recognized syndrome that affects other organs or features.
And non-syndromic HHI, hearing loss only, is the more common form.
Yes. The source indicates it accounts for the majority, nearly 2/3 of all hereditary hearing loss cases. Within this non-syndromic category, the pattern of inheritance is key. Autosomal recessive inheritance, where a child needs to inherit a mutated copy of the gene from both parents, is the most frequent pattern, accounting for perhaps 70–80% of non-syndromic cases. This type, often denoted with the locus prefix DFNB, frequently results in congenital, present at birth, hearing loss that is typically severe to profound. Autosomal dominant inheritance, where inheriting just one mutated copy of the gene is sufficient to cause hearing loss, accounts for maybe 15–20%. This type, denoted DFNA, often has a later onset, perhaps in childhood, adolescence, or even adulthood, tends to be more variable in severity, and is often progressive, getting worse over time. Less common patterns include X-linked inheritance, DFNX, affecting primarily males, and mitochondrial inheritance, passed down only from the mother, which account for less than 5% combined.
The sheer number of genes involved in just the non-syndromic HHI sounds potentially overwhelming for diagnosis.
It is quite remarkable and reflects the incredible complexity of developing and maintaining our auditory system. The source states that over 150 different genetic loci, locations on chromosomes linked to non-syndromic deafness, have been mapped, and numerous specific genes within those loci have now been identified. It's a testament to the progress in human genetics. The source categorizes some of these genes by the function of the protein they code for, which gives you a sense of the different biological processes involved.
Some code for crucial structural proteins within the cochlea, like myosin proteins, for example, MYH9, MYO7A, involved in hair cell structure and function. Others are transcription factors, TGPO3F4, that regulate the expression of other genes during your development. Some code for ion channels, for example, KCNQ4, essential for the electrical activity of hair cells. And a very important group codes for gap junction proteins, for example, GJB2, GJB3, GJB6, which form channels allowing communication and nutrient transport between supporting cells in the cochlea.
That's fascinating. Problems in structure, development, electrical function, or even cell-to-cell communication can all lead to deafness. And you mentioned some genes can cause different forms depending on the specific mutation.
Yes, intriguingly, the source notes several genes, including GJB2, coding for connexin 26, TECTA, coding for alpha-tecterin, a protein in the tectorial membrane, and TMC1, a transmembrane channel-like protein, can be responsible for both autosomal dominant and autosomal recessive forms of non-syndromic HHI, depending on the specific type and location of the mutation within the gene. This adds another layer of complexity to genetic counseling.
The DJB2 gene, coding for connexin 26, seems particularly high yield based on the source. Why is it so important?
It's highly important because mutations in GJB2 are the single most common cause of hereditary hearing loss in many populations. The source highlights it as being responsible for nearly 20% of all childhood deafness, and roughly half of all genetic deafness in children worldwide is attributable to GJB2 mutations. That's huge.
Wow, half of genetic deafness from one gene.
Predominantly due to its role in autosomal recessive deafness, DFNB1. Two specific mutations in GJB2, a fring shift mutation called 35del-G, common in Caucasian populations, and another called 167del-T, together account for over 50% of all recessive GJB2-related deafness. The 167del-T mutation is noted to be particularly prevalent in the Ashkenazi Jewish population, where the carrier frequency is high, leading to homozygous affected individuals inheriting two copies in approximately 1 in 1765 births.
So, while these common mutations exist and can be tested for easily, finding the cause might require looking at the whole gene.
Right. Since many other mutations exist across the GJB2 gene, the source notes that complete sequencing of the GJB2 gene is often required to identify all recessive causes, especially if testing for the common mutations is negative. It also points out an interesting phenomenon called variable expressivity. Even within the same family, individuals inheriting the exact same GJB2 mutations can sometimes have different degrees of hearing loss, ranging from moderate to profound. This suggests that other modifying genetic factors or perhaps environmental influences can impact the final clinical outcome.
And there's that really interesting concept of digenic inheritance mentioned as well. How does that work?
Yes, this further illustrates the complexity. Digenic inheritance means that mutations in two different genes are required together to cause the condition. The source gives the example involving the connexin genes. Hearing loss can occur when someone inherits a single pathogenic mutation in the GJB2 gene, which wouldn't cause deafness on its own in a recessive manner, and also inherits a specific deletion mutation affecting the nearby GJB6 gene, coding for connexin 30. Neither mutation alone is sufficient, but the combination results in hearing loss. This really raises an important question. How many other complex genetic interactions like this are at play in determining our hearing ability or susceptibility to hearing loss? It suggests the genetic landscape is incredibly intricate and not always straightforward Mendelian inheritance.
It definitely seems like it's rarely just one simple gene causing the issue. You also mentioned earlier that some non-syndromic genes are linked to progressive loss and that genetics plays a role in presbycusis too.
Yes, several of the non-syndromic genes, particularly those causing dominant forms, DFNA, are associated with hearing loss that is progressive, starting later in life and worsening over time. And genetics certainly contribute significantly to susceptibility to age-related hearing loss, presbycusis. It's likely a complex interplay between multiple genetic susceptibility factors and accumulated environmental insults, especially lifetime noise exposure. Identifying these genetic factors is an active area of research. Furthermore, genetics can influence how vulnerable someone is to specific types of acquired hearing loss. The source gives two key examples. Susceptibility to aminoglycoside autotoxicity. Hearing loss caused by certain antibiotics like gentamicin is strongly linked to specific mutations in mitochondrial DNA, which are maternally inherited. And there's growing evidence for genetic factors influencing individual susceptibility to noise-induced hearing loss as well.
So your genes can literally make you more susceptible to damage from loud sounds or certain medications. That's important for personalized risk assessment. What about the other major category, syndromic HHI? Hearing loss is part of a bigger picture.
Right. In syndromic HHI, the hearing loss is just one component of a broader genetic disorder affecting multiple parts of the body. The source states there are over 400 known genetic syndromes that include hearing impairment as a feature. Recognizing these syndromes is crucial because it allows for diagnosis of the underlying condition and appropriate management of the other associated health issues.
Can you give us a few examples from the table mentioned in the source just to illustrate the range of associations?
Absolutely. Usher syndrome is a classic example, maybe the most common syndromic form, combining SNHL, usually congenital and severe, with retinitis pigmentosa, a progressive eye disease leading to tunnel vision and blindness. Waardenburg syndrome involves hearing loss, variable severity, often alongside distinctive pigmentary abnormalities, like a white forelock of hair, different colored eyes, heterochromia iridis, or patches of depigmented skin. Pendrell syndrome combines SNHL with defects in thyroid gland function, goiter. Alport syndrome links progressive SNHL with kidney disease, nephritis, and sometimes eye abnormalities. Dravel and Long-Nielsen syndrome is particularly important to recognize as it involves profound congenital SNHL and a cardiac abnormality, a prolonged QT interval on the EKG, which puts affected individuals at high risk for sudden cardiac death if not managed appropriately. Neurofibromatosis type 2, NF2, is characterized by the development of bilateral vestibular schwannomas, tumors on both auditory nerves, leading to progressive SNHL, tinnitus, and balance problems, often starting in late teens or early adulthood. Certain mitochondrial disorders, which affect energy production in cells throughout the body, like MELS, MERF, and PEO syndromes, can also include SNHL as part of their constellation of neurological and muscular symptoms. What's truly fascinating here, and clinically vital, is precisely that connection, how identifying hearing loss, especially in childhood, can be the first clue leading to the diagnosis of a broader systemic condition affecting seemingly unrelated systems like the eyes, kidneys, heart, thyroid, or nervous system. It underscores the interconnectedness of our biology.
It absolutely does. Really highlights why a thorough evaluation is so important. Okay, we've covered the types and causes in great detail. Now, how do professionals actually approach diagnosing hearing loss when a patient comes in with concerns? What's the systematic process described in the source?
The source outlines a clear, logical approach with 4 key goals when evaluating a patient presenting with hearing complaints. 1. Determine the nature of the loss. Is it conductive, sensorineural, or mixed? 2. Determine the severity. Is it mild, moderate, severe, or profound? 3. Identify the likely anatomical site of the problem: external ear, middle ear, inner ear, cochlea, or central auditory pathway, nerve brainstem. And 4. Pinpoint the specific etiology or underlying cause if possible.
And it all starts, as always in medicine, with taking a thorough history from the patient. What are the key questions to ask to understand the hearing loss itself?
You need to nail down the fundamental characteristics of the hearing loss. Its duration, how long has it been noticeable? Laterality, is it one ear or both? Onset, did it start suddenly or gradually insidiously? And progression, is it stable, slowly getting worse, or rapidly worsening?
And those associated symptoms we discussed earlier become absolutely crucial clues during the history taking.
Exactly. Actively asking about associated symptoms is vital because they provide critical information pointing towards the potential anatomical location and underlying cause. For instance, asking about tinnitus, ringing, vertigo, stinning, imbalance, oral fullness, pressure, otorrhea, ear discharge, headache, facial nerve weakness or numbness, paresthesia, tingling in the head or neck.
Why ask about these specifically? How do they help localize?
Well, think back to our discussion of causes. Vertigo strongly suggests involvement of the inner ear's vestibular system, or the vestibular nerve. For example, Meniere's vestibular neuritis, SSED vestibular schwannoma. Otorrhea points directly to a problem in the external or middle ear. For example, otitis externa, otitis media, cholesteatoma. Facial weakness or trigeminal numbness accompanying hearing loss immediately raises concern for a potential lesion compressing those cranial nerves, most commonly a tumor in the cerebellopontine angle. Oral fullness is common with middle ear fluid or Meniere's, so these symptoms act like signposts.
And specific patterns of symptoms emerging from the history can serve as powerful diagnostic clues as well.
They absolutely do. The source explicitly highlights several characteristic symptom constellations. Sudden unilateral hearing loss, maybe with tinnitus, but usually without vertigo, needs prompt evaluation. Could be a viral inner ear infection, labyrinthitis, or idiopathic sudden SNHL, but critically must rule out a vestibular schwannoma or even a stroke affecting the auditory pathways. Any unilateral hearing loss, whether sensory or conductive, will likely cause difficulty localizing sounds and understanding speech and background noise. gradual, progressive hearing loss. Could be common things like presbycusis, NAHL, or otosclerosis. But a slowly growing vestibular schwannoma or evolving Meniere's disease also fit this pattern. What about a small vestibular schwannoma? Often presents initially with just asymmetric SNHL, often subtle high-frequency loss, maybe tinnitus, and often vague imbalance rather than true vertigo. Cranial neuropathy involving the trigeminal facial numbness or facial nerve weakness tends to occur only with larger tumors. Meniere's disease. Look for that classic episodic tetrad. Recurring vertigo spells, fluctuating SNHL, often low frequency, fluctuating tinnitus, and fluctuating oral fullness. Experiencing sound-induced vertigo, Tullio phenomenon, autophony, hearing internal body sounds, or hearing loss with pressure changes. These are the classic symptoms strongly suggestive of superior semicircular canal dehiscence or other third window problems. Hearing loss accompanied by persistent or recurrent ear discharge, otorrhea. Think chronic otitis media, or, importantly, consider an underlying cholesteatoma.
Those symptom patterns are invaluable for narrowing down the diagnostic possibilities right from the start. What about the physical examination itself? What are the key components?
The exam starts with careful visual inspection of the external ear, pinna, and then moves inward using an otoscope to examine the external auditory canal and the tympanic membrane, eardrum. The source emphasizes the importance of safely removing any obstructing cerumen or debris to get a clear view. Suction or specialized ear loops are preferred over irrigation, especially if there's any suspicion of an eardrum perforation, as irrigation could flush contaminants into the middle ear.
What are you looking for when inspecting the eardrum?
You assess its appearance. Is it intact, red, bulging, retracted? You look for landmarks like the malleus bone handle. You check for fluid levels or bubbles behind the drum, indicating effusion. You specifically look at both the main part of the drum, pars tensa, and the smaller upper part, pars flaccida, for any signs of retraction pockets indrawing of the drum, which are significant potential precursors or signs of cholesteatoma, often indicating chronic eustachian tube dysfunction. Pneumatic otoscopy is also important using an otoscope with a rubber bulb, insufflator, to gently puff air into the sealed ear canal. This allows you to assess the mobility or compliance of the eardrum. A mobile drum moves briskly. A drum with fluid behind it, effusion, or negative pressure will be immobile or move poorly.
Are other areas examined besides the ear itself?
Yes, definitely. Given the connection via the eustachian tube, inspecting the nose, nasopharynx using a mirror or endoscope if needed, and the upper respiratory tract as part of a thorough ear evaluation. The source specifically highlights that any adult presenting with unilateral serious otitis media, fluid behind the drum on one side, or unexplained persistent ear pain, warrants a careful fiber optic examination of the nasopharynx to rule out an occult neoplasm, like nasopharyngeal carcinoma, obstructing the eustachian tube opening back there. And as we noted regarding potential central causes, performing a relevant cranial nerve examination is important, especially checking facial nerve function, CNV, and trigeminal nerve sensation, CNV, particularly if a cerebellopontine angle tumor is suspected based on the history or audiometry.
Okay. Beyond the visual exam with the otoscope, there are the classic tuning fork tests, Rinn and Weber. How do these simple bedside tests help differentiate types of hearing loss?
The Rinn and Weber tests, typically performed using a 512 Hz tuning fork, as lower frequencies produce more vibration sensation, are incredibly useful screening tools. They help differentiate conductive from sensorineural hearing loss and can help confirm or correlate with findings from formal audiometry. The Winn test directly compares the patient's perception of sound loudness via air conduction, AC, versus bone conduction, BC, in one ear at a time. You strike the fork, hold the tines near the opening of the ear canal, testing AC, and then immediately place the vibrating base firmly on the mastoid bone behind the ear, testing BC. You ask the patient which position sounds louder.
And the normal result is hearing it louder by the ear canal.
Yes. Normally, and also in cases of pure sensorineural hearing loss, air conduction is perceived as louder than bone conduction, ACBC. This is termed a positive Rinn test. However, if there is a significant conductive hearing loss, the source suggests about 30 dBs or more, the patient will perceive the sound as louder when the fork is placed on the mastoid bone, BCAC. This is termed a negative Rinn test.
Why does that happen? Why is bone louder if the outer middle ear is blocked?
It seems counterintuitive, but the source explains the elegant reason why. The conductive blockage, like fluid or vesicular fixation, impedes the sound energy traveling through the normal air conduction pathway. However, the bone-conducted sound bypasses this blockage entirely, directly vibrating the skull and stimulating the inner ear fluids, So in the presence of a conductive loss, this direct bone conduction route becomes relatively more efficient than the blocked air conduction route, making the BC sound seem louder in that ear.
That explanation makes the counterintuitive result make sense. Okay, so Rin compares AC versus BC in one here. What about the Weber test?
The Weber test helps determine if a unilateral one-sided hearing loss is conductive or sensorineural, or helps confirm if hearing is symmetrical. You strike the tuning fork and place its base firmly on the midline of the patient's head. Common spots are the center of the forehead, the top of the head vertex, or even the front teeth. You then ask the patient where they perceive the sound, in the middle, or louder in the right ear, or louder in the left ear, i.e., does it lateralize?
So what does lateralization tell you? Where the sound goes?
It's crucial. Here's the key interpretation. With a unilateral conductive hearing loss, the sound lateralizes to the affected bad ear.
Again, seems backward. Why to the bad ear?
It relates to masking, similar to the Rin explanation. The source explains why. The unaffected, good ear, hears the bone-conducted sound, but it also hears ambient room noise coming through its normal air conduction pathway. This ambient noise slightly masks the perception of the bone-conducted sound in the good ear. The ear with the conductive loss, however, is blocked from hearing that ambient noise effectively. Therefore, the bone-conducted sound isn't masked and is perceived as relatively louder in the conductively impaired ear. What's truly fascinating here is how these simple tests reveal the physics of sound transmission and perception.
Okay, that's clever. Blocked ear doesn't get masked, so it hears the vibration better. What about unilateral SNHL?
With a unilateral sensorineural hearing loss, the sound lateralizes to the unaffected, good ear. This one is more straightforward. The inner ear or nerve on the affected side isn't processing the sound signal effectively, so the brain perceives the sound as coming from the side with better neural function. The source notes you typically need about a 5 dB difference in hearing thresholds between the ears for the lateralization in the Weber test to be clearly perceived by the patient.
So tuning forks give you quick, valuable clues at the bedside, but the real detailed quantification comes from formal laboratory audiology assessment.
Absolutely. Audiologic assessment performed by a certified audiologist is the gold standard for defining the type, degree, and configuration of hearing loss. The source lists the minimum battery of tests usually required for a comprehensive evaluation. These include pure tone, air, and bone conduction threshold testing, speech audiometry including speech reception threshold, SRT, and word recognition discrimination testing, and middle ear assessment using tympanometry and acoustic reflex threshold testing, and sometimes reflex decay. The overall goal of this battery is to screen the function of the entire auditory system, from the outer ear to the central pathways, and crucially to help differentiate sensory cochlear pathology from neural retrocochlear, i.e. auditory nerve or brainstem pathology.
Okay, let's break down pure tone audiometry first. That's the standard hearing test most people think of, right? With the beeps.
It's performed by an audiologist in a calibrated sound-treated booth to ensure accurate results without interference from outside noise. Yeah. The audiologist presents pure tones single-frequency sounds, typically ranging from 250 Hz, low pitch, up to 8,000 Hz, high pitch, covering the main frequencies important for speech understanding. These tones are presented at varying intensity levels, loudness, to determine the softest level at which the patient can reliably detect the tone at each frequency. That softest level is the patient's hearing threshold for that frequency. It's done first using headphones or insert earphones to measure air conduction thresholds, testing the whole pathway, and then using a bone oscillator placed on the mastoid bone or forehead to measure bone conduction thresholds, bypassing the outer and middle ear to test inner ear nerve function directly. If there's a significant difference in hearing between the two ears, masking noise, a static-like sound, is delivered to the non-test ear to prevent it from inadvertently hearing the test tone via crossover through the skull, ensuring you're truly measuring the threshold of the intended test ear.
Right, isolating the ear being tested. And the results are plotted on that chart everyone recognizes, the audiogram.
Yes, the audiogram is the standard graphical representation of hearing thresholds. It plots the intensity threshold in decibels hearing level, dBHL, on the vertical axis, with 0 dBHL representing average normal hearing for young adults, and increasing dB values indicating worse hearing, against the frequency in hertz on the horizontal axis, low pitches on the left, high pitches on the right. The source reminds us that the decibel scale is logarithmic, representing a ratio of sound pressure. A 6 dB increase roughly doubles the sound pressure, while a 20 dB increase represents a 10-fold change in pressure. Importantly for perception, subjective loudness roughly doubles for approximately every 10 dB increase in sound pressure level. Pitch perception relates to frequency, but it's a complex psychoacoustic relationship, though higher frequencies are generally perceived as higher pitch.
How do you actually read the audiogram to determine the type and severity of hearing loss?
The pattern of the plotted thresholds tells you everything. First, the overall level of the thresholds indicates the severity. 0-25 dBHL is generally considered normal range, 26-40 dB mild loss, 41-55 moderate, 56-70 moderately severe, 71-90 severe, and above 90 dB profound loss. Second, comparing the air conduction thresholds, often plotted with an O symbol for the right ear, X for the left, to the bone conduction thresholds, often plotted with symbols like LAL, LACI, where determines the type of loss. If the air and bone conduction thresholds are essentially the same, within 10 dB, and both are below the normal range, it indicates a sensorineural hearing loss, SNHL. The problem is in the inner ear or beyond. If the bone conduction thresholds are within the normal range, but the air conduction thresholds are significantly worse, showing an air-bone gap of more than 10-15 dB, it indicates a conductive hearing loss. The inner ear is working fine, normal BC, but sound isn't getting conducted effectively through the outer or middle ear, poor AC. If both bone conduction thresholds are below normal and air conduction thresholds are even worse, maintaining a bone gap, it indicates a mixed hearing loss, a combination of conductive and sensorineural problems.
And the shape or configuration of the loss across frequencies gives clues to the cause.
Yes, absolutely. The pattern can be very informative, as we touched on earlier. Conductive losses related more to increased mass in the middle ear, like fluid, tend to affect higher frequencies more predominantly. Conductive losses related more to increased stiffness, like early otosclerosis fixing the stapes, tend to affect low frequencies more. If both mass and stiffness are involved, all frequencies might be affected relatively equally, a flat conductive loss. SNHL generally tends to show a sloping pattern, affecting the higher frequencies more than the lower frequencies, especially in common causes like presbycusis, age-related loss, or NIHL, though NIHL has that specific 3 and 6 kilohertz notch.
Yeah.
However, Meniere's disease characteristically might show a low-frequency SNHL, at least initially, or sometimes a peaked or flat pattern. Vestibular schwannomas often affect higher frequencies first, but the pattern can be quite variable. So the pattern provides clues but isn't always definitive on its own.
Okay, so pure tone audiometry gives you the detailed map of hearing sensitivity at different pitches. What about speech audiometry? That seems crucial for assessing real-world hearing function and clarity.
Exactly. Hearing pure tones in a quiet booth is one thing. Understanding the complex, rapidly changing sounds of speech, especially in the presence of background noise, is a much more demanding task for the auditory system. It requires precise neural timing and processing. Speech audiometry directly assesses this functional ability. The first measure is the speech reception threshold, SRT. This determines the softest intensity level, in dBHL, at which the patient can correctly recognize and repeat 50% of simple, familiar, two-syllable words, spondy words like baseball, hot dog, ice cream. The SRT should generally agree closely, within about 10 dBs, with the average of the pure tone thresholds in the main speech frequencies, the G 500 on 1000, 2000 Hz, serving as a reliability check for the pure tone results.
Okay, that's the softest level for speech. What about the word recognition or speech discrimination scores? How clearly can they understand speech?
This is arguably the most important measure for assessing functional hearing ability, especially related to SNHL. For this test, lists of single-syllable words, which are phonetically balanced, meaning the speech sounds in the lists occur with roughly the same frequency as they do in conversational English, are presented at a comfortable listening level, usually about 30-40 dBs above the patient's SRT. The patient simply repeats the word they hear, and the score is calculated as the percentage of words repeated correctly. This score reflects the clarity of hearing, independent of just loudness.
How do you interpret those word recognition scores, particularly in trying to differentiate between a cochlear sensory problem and a neural retrocochlear problem?
This is where word recognition scores become incredibly valuable diagnostically. Patients with normal hearing or a purely conductive hearing loss typically achieve excellent word recognition scores, usually 88-100% correct when the words are presented loud enough. With SNHL, however, the scores can be highly variable, ranging from near normal to very poor, 0%. But here is a critical clinical distinction highlighted repeatedly in the source. Neural lesions, like a vestibular schwannoma affecting the auditory nerve, tend to cause significantly greater deficits in speech discrimination compared to cochlear lesions, like hair cell damage, that produce a similar degree of pure tone hearing loss.
So someone with a nerve problem might have only mild loss on the pure tone test, but terrible speech understanding.
Exactly. The source emphasizes that finding a word recognition score that is worse than expected based on the severity of the SNHL on the audiogram, especially if the loss is asymmetric, is a key red flag suggesting a possible retrocochlear lesion, like a vestibular schwannoma. Another important sign mentioned is rollover. This is when the word recognition score actually gets worse, as the presentation intensity is increased significantly above the level where the best score was obtained. This deterioration at high intensities is also highly suggestive of a problem in the eighth nerve, or central auditory pathways, rather than just the cochlea.
That's a really powerful differentiator hidden within the standard tests. Okay, what about tympanometry? What does that tell us?
Tympanometry is an objective test that specifically measures the impedance, resistance to movement, or its inverse, compliance, ease of movement, of the middle ear system, primarily the eardrum and ossicles. It does this by varying the air pressure in the sealed external ear canal and measuring how much sound energy is reflected back from the eardrum at different pressures. It's invaluable for detecting conditions like middle ear fluid, effusion, eardrum perforations, or problems with eustachian tube function. The result is plotted graphically as a tympanogram.
And the shape of that tympanogram plot tells you what's likely happening in the middle ear.
Yes, the shape is highly informative. The source described the classic tympanogram types based on the Jurger classification system. Type A is the normal shape, a sharp peak in compliance occurring at or near 0 dBA, atmospheric pressure. This indicates normal middle ear pressure and mobility. It's seen in people with normal hearing or those with pure SNHL, where the middle ear is fine. Type B is a flat or very shallowly rounded tracing with no distinct peak. This indicates very little change in compliance as pressure is varied, suggesting the middle ear system is very stiff or blocked. It's highly suggestive of middle ear effusion, fluid behind the eardrum, or potentially a hole in the eardrum if the ear canal volume measured is very large. Type C shows a clear peak, but the peak is shifted significantly to the negative pressure side, e.g. negative 150 dBA or lower. This indicates significant negative pressure within the middle ear space, typically due to eustachian tube obstruction or dysfunction. Type AD, for deep or discontinuity, shows a very high, often off-scale peak compliance. This suggests the middle ear system is overly compliant or flaccid, typically seen when there's a discontinuity or break in the ossicular chain, or perhaps a very thin, healed eardrum, monomeric TM. Type AS, for shallow or stiffness, shows a clear peak near zero pressure, but the peak is much shallower or lower in amplitude than normal, indicating reduced maximum compliance. This suggests stiffness in the middle ear system, classically seen in conditions like otosclerosis where the stape is becoming fixed.
So tympanometry gives you really useful objective information, specifically about the status of the middle ear mechanics. What about the acoustic reflex test? That's often done along with tympanometry.
Right. The acoustic reflex is the involuntary contraction of the stapedius muscle, a tiny muscle attached to the seats bone in the middle ear, which occurs in response to a loud sound, typically 70-100 dKA above threshold. This contraction stiffens the ossicular chain, slightly decreasing the compliance of the middle ear system. Tympanometry equipment can detect this small change in compliance when a loud activating sound is presented to either the same ear, ipsilateral reflex, or the opposite ear, contralateral reflex. Measuring the threshold, the softest loud sound that elicits the reflex, and presence-absence of the reflex is useful clinically.
How does it help differentiate hearing loss causes or localized problems?
It provides several useful pieces of information. First, it can help differentiate between certain conductive causes. For example, the reflex is typically absent in otosclerosis because the fixed stapes cannot be moved by the stapedius muscle contraction. However, the reflex might be present, though maybe at elevated thresholds, in conductive losses due to inner ear third window problems, because the middle ear reflex pathway itself is intact, even if the inner ear is leaking energy. Second, in cases of SNHL, the pattern of reflex thresholds can help differentiate sensory, cochlear, from neural loss. In cochlear loss, reflexes are often present, but at reduced sensation levels, meaning they occur at lower dB levels above threshold than normal, or elevated absolute thresholds. An absent reflex in the presence of SNHL is less specific, but can occur with severe cochlear loss, or any significant neural pathway problem. Third, acoustic reflex decay testing can be particularly helpful in differentiating sensory versus neural loss. In this test, a sustained loud tone is presented for about 10 seconds. In normal ears or those with cochlear loss, the reflex contraction is sustained. However, in neural losses affecting the auditory nerve, like a vestibular schwannoma, the nerve fibers fatigue quickly, and the reflex contraction cannot be maintained. It decays significantly, usually by 50% or more, during the 10-second stimulation. This rapid decay is a strong sign of retrocochlear pathology. Lastly, the pattern of present and absent ipsilateral and contralateral reflexes can help localize lesions along the facial nerve pathway, as the stapedius muscle is innervated by the facial nerve.
Okay, that's quite informative. Now, there are also tests that measure sounds produced by the ear itself, or the electrical activity of the auditory system directly.
Yes, these are highly valuable objective tests. First, otoacoustic emissions, OAEs. These are faint sounds that are actually generated within the cochlea, specifically by the modal activity of the outer hair cells. Remember that cochlear amplifier. These sounds travel back out through the middle ear and can be measured by a sensitive microphone placed in the ear canal.
The ear makes its own sounds. Wow. What's the significance of measuring them?
The presence of OAEs is a strong indicator that the outer hair cells are healthy and functioning normally, and that the conductive pathway, middle ear, is clear enough to allow these faint sounds to escape. OAEs are extremely useful for several reasons. They are widely used for objective newborn hearing screening programs if OAEs are present. It suggests the baby's cochlea is likely working well. Clinically, they help assess auditory thresholds indirectly, and importantly, they can help distinguish sensory from neural hearing loss. If OAEs are present but the patient still has SNHL, 4AG, and abnormal ABR, it strongly suggests the problem lies beyond the outer hair cells, in the inner hair cells, synapses, auditory nerve, or central pathways, consistent with auditory neuropathy spectrum disorder. If OAEs are absent, it usually indicates significant cochlear damage, specifically outer hair cell loss, or a conductive blockage preventing their measurement.
Okay, so OAEs check the outer hair cells. What about measuring the electrical responses further up the pathway?
Those are the auditory evoked potentials or evoked responses. These tests measure the tiny electrical potentials generated by different parts of the auditory system in response to sound stimuli, usually clicks or tone bursts, using electrodes placed on the scalp or near the ear. Electrocochleography, ECOG, measures the earliest potentials arising directly from the cochlea and the auditory nerve. It records the cochlear microphonic, reflecting mainly outer hair cell activity, the summating potential, reflecting mainly inner hair cell and possibly IHC synapse activity, and the compound action potential, AP, of the auditory nerve, wave I of the ABR. Clinically, ECOG's primary use, as mentioned in the source, is in the diagnosis of Meniere's disease or endolymphatic hydrops, where an abnormally elevated ratio of the summating potential amplitude to the action potential amplitude, SPAP ratio, is a characteristic finding in many affected patients.
And brainstem auditory evoked responses, BARs or ABRs. These sound like they measure deeper into the brain.
Exactly. ABRs, also called BARs, measure a series of electrical potentials generated sequentially by the auditory nerve and the various nuclei along the auditory pathway within the brainstem, like the cochlear nucleus, superior olivary complex, lateral lemniscus, inferior colliculus, in the first 10-15 milliseconds after a sound stimulus. These potentials appear as distinct waves, labeled I through V or SIVE, recorded from scalp electrodes. ABRs are incredibly versatile and valuable. The source highlights their main uses. 1. Differentiating the site of SNHL comparing wave I, nerve latency and amplitude, to later waves, brainstem, helps distinguish cochlear, sensory, from retrocochlear, neural pathology. Delays between waves or absent later waves point to neural problems. 2. Assessing the integrity of the auditory nerve and brainstem pathways, useful in diagnosing tumors, demyelinating diseases like MS or effects of stroke or trauma. 3. Providing objective estimation of hearing thresholds when behavioral responses are unreliable or unobtainable, such as in infants, young children, or individuals suspected of feigning hearing loss, non-organic hearing loss. 4. Used for intraoperative monitoring during surgeries near the auditory nerve or brainstem, like vestibular schwannoma removal, to help preserve hearing function. 5. Part of the battery of tests used in determining brain death.
Wow, ABR is really a workhorse test. And you also mentioned earlier a test that uses sound to evaluate the vestibular system, the VEMP test.
Yes, the vestibular evoked myogenic potential, VEMP test. This is a fascinating test that investigates the function of the otolith organs, the saccule and utricle, which sense linear acceleration and gravity and their corresponding vestibular nerve pathways using a high-intensity acoustic stimulus, loud clicks or tone bursts, presented to the ear. There are two main types. The cervical VEMP, CVEMP, is a reflex response recorded from the contracted sternocleidomastoid, SCM muscle in the neck. It primarily reflects the function of the saccule and the inferior branch of the vestibular nerve. The ocular VEMP, OVEMP, is recorded from electrodes placed under the eyes, measuring responses in the extraocular muscles, inferior oblique. It primarily reflects the function of the utricle and the superior branch of the vestibular nerve.
How are VEMPs clinically useful in the context of hearing and balance disorders?
They provide unique information about otolith function, which isn't assessed by tests like V&G that mainly look at the semicircular canals. The source notes several key clinical uses for CVMAPs. They can be diminished or absent in conditions affecting the saccule or inferior vestibular nerve, such as later stages of Meniere's disease, vestibular neuritis affecting the inferior nerve, benign paroxysmal positional vertigo, BPPV, or vestibular schwannomas compressing the nerve. But what's particularly important and diagnostically powerful is that VMP thresholds, the low sound intensity needed to elicit a response, are characteristically lower than normal, meaning the system is hypersensitive to sound, in patients with inner ear third window disorders, most notably superior semicircular canal dehiscence, SSCD. They may also be lower in other conditions causing inner ear dehiscence or paralymphatic fistula. This finding of abnormally low VEMP thresholds is a strong corroborating sign for these conditions. OVMPs are particularly useful for assessing superior vestibular nerve function and can be abnormal in superior vestibular neuritis.
Okay, that covers the main electrophysiological and functional tests. Finally, imaging studies, CT and MRI, are obviously a critical part of the workup, depending on what pathology you suspect.
Exactly. The choice between CT and MRI depends entirely on what you need to visualize: bone or soft tissue nerves. High-resolution CT scanning of the temporal bone is the ideal modality for evaluating fine bony detail. The source highlights its use for assessing external auditory canal caliber, for example, in stenosis or atresia, the integrity of the ossicular chain, looking for erosion or discontinuity, evaluating middle ear and mastoid disease like fluid, cholesteatoma, inflammation, and identifying bony congenital malformations of the inner ear. CT is excellent at detecting bone erosion caused by chronic otitis media or cholesteatoma, and as we mentioned, specific CT reconstructions, like partial or stent reviews, are necessary to properly visualize and diagnose superior semicircular canal dehiscence.
So CT for the bone structure and middle ear space, and MRI is better for...
MRI is vastly superior for visualizing soft tissues, nerves, and the brain. Therefore, it's the preferred imaging study for suspected retrocochlear pathology. This includes diagnosing vestibular schwannomas, meningiomas, and other regions within the cerebellopontine angle or internal auditory canal. It's also used to look for brainstem demyelination, as in MS, brain tumors affecting the auditory pathways, or evidence of stroke. MRI with gadolinium contrast enhancement is typically essential for tumor detection. The source does note that both CT and MRI can be useful and are often complementary for evaluating complex inner ear malformations and for assessing cochlear fluid spaces and nerve presence, cochlear patency, prior to considering cochlear implantation surgery.
That's an incredibly comprehensive set of diagnostic tools clinicians use to piece together the full puzzle of a patient's hearing loss, the nature, severity, anatomical site, and likely cause. Now let's talk about the crucial part: treatment and management strategies aimed at restoring or aiding hearing.
Right. The overarching principle laid out in the source is a familiar one by now. Conductive hearing losses, which are typically caused by physical blockages or mechanical problems in the outer or middle ear, are often amenable to surgical correction or medical treatment aimed at fixing the underlying problem. Sensorineural losses, on the other hand, which involve damage to the delicate sensory cells of the inner ear or the auditory nerve pathway, are usually permanent and thus are typically managed, rather than cured, with amplification devices like hearing aids or implantable technologies like cochlear implants.
So for conductive loss, the goal is often to fix the mechanics.
Yes, that's frequently the primary goal. The source lists several examples. For conductive loss due to congenital external canal closure, oral atresia, where conventional hearing aids aren't feasible, bone-anchored hearing aids, BAHA, can be very effective. These transmit sound directly to the inner ear by vibrating the skull bone, bypassing the blocked canal. Tympanic membrane perforations, holes in the eardrum, resulting from chronic otitis media or trauma, can often be surgically repaired with a tympanoplasty procedure, which the source reports is highly successful, over 90%, in closing the perforation and often improving hearing. Otosclerosis causing stapes fixation and conductive hearing loss is very effectively treated with stapedectomy or stapedidomy surgery, replacing the fixed stapes with a prosthesis. Again, with very high success rates, 95%, in restoring the mechanical transmission and improving hearing significantly. Middle ear effusions, suet buildup, a common cause of conductive loss, especially in children, are effectively treated by inserting tympanostomy tubes, ear tubes, through the eardrum. These tubes ventilate the middle ear space, allowing fluid to drain or resolve, and typically result in a prompt return to normal or near normal hearing. And it's worth noting that even for conductive losses that aren't surgically corrected, or if surgery isn't desired, conventional hearing aids can still be effective and are generally well tolerated.
Okay, so good options often exist for conductive losses. But for SNHL, where the inner ear or nerve is damaged, the approach shifts more towards management and rehabilitation.
Precisely. Since we usually can't repair the damaged neural structures, the focus is on making the best use of the remaining auditory function or bypassing the damaged parts altogether. For mild, moderate, and severe degrees of SNHL, conventional hearing aids are the primary management tool. The source highlights how far hearing aid technology has advanced. Modern digital aids are incredibly sophisticated. They offer miniaturization, some are nearly invisible, fitting deep in the ear canal, which helps address cosmetic concerns or stigma, advanced sound processing features, multiple microphones, and directional technology designed to improve the signal-to-noise ratio, helping users focus on speech in noisy environments. They can also offer wireless connectivity to phones and other devices.
But as we discussed, they have limitations, especially regarding clarity if the underlying SNHL is severe or involves poor neural processing.
That remains their fundamental limitation. Hearing aids amplify sound, making it louder and more accessible, but they cannot fully restore the clarity that is lost due to damage within the cochlea or auditory nerve, especially in conditions like presbycusis or significant NIHL. They can't fix the distorted or incomplete signal being sent from the periphery. The source notes that hearing aids may provide limited functional benefit if the patient's word recognition ability drops below about 50%, even with amplification.
Right. And the cost can be a significant barrier for many people needing them.
It definitely can be, representing a major healthcare access challenge. But, as we discussed, that's why the emergence of the FDA-approved over-the-counter OKC hearing aid category is potentially so important. The source speculates, and it's a widely held view, that this could fundamentally change the landscape of hearing rehabilitation for adults with perceived mild to moderate hearing loss. By allowing direct-to-consumer sales, it's expected to reduce costs, spur innovation, increase competition, and ultimately make basic amplification options much more accessible to millions who currently go untreated. It's a paradigm shift in progress.
That could indeed be a true democratization of hearing health access for many. What about individuals who have profound hearing loss in only one ear, a condition often called single-sided deafness, SSD? They have unique challenges.
Yes, SSD presents very distinct functional difficulties. The primary ones are 1. An inability to localize the direction of sounds accurately, because localization relies heavily on comparing timing, intensity differences between the two ears. 2. Significant difficulty understanding speech when the sound source or competing background noise is located on the side of the deaf ear. The head shadow effect blocks sound from easily reaching the good ear. Several types of devices exist specifically to help mitigate these problems by routing sound from the deaf side over to the hearing ear. These include CROS, contralateral routing of signal, hearing aid systems. These consist of a microphone unit worn in the deaf ear that picks up sound and wirelessly transmits it to a receiver hearing aid worn on the hearing ear. Alternatively, bone-anchored hearing aid, BHA devices can be used. A small titanium implant is surgically placed in the skull bone behind the deaf ear. An external processor attaches to this implant and transmits sound energy as vibrations through the skull directly to the cochlea of the contralateral opposite hearing ear. For individuals who have profound loss on one side and also some degree of SNHL in their better ear, a bicro system can be used. This combines the cross-Baha concept, routing the sound from the poorer ear, with necessary amplification provided by a hearing aid for the better ear.
But these CRS and BIH solutions primarily just route the sound across the head. They don't actually restore hearing function in the deaf ear itself, right?
That's the crucial limitation the source notes for CROS and traditional BAHA use in SSD. They help with awareness of sounds on the deaf side, but don't provide true binaural hearing with two ears. However, here's another area of significant advancement. Cochlear implants, CIs, are increasingly being used successfully for managing SSD in carefully selected candidates.
A cochlear implant for someone who still has one good ear, how does that help?
What's fascinating here is the potential benefit beyond just sound awareness. While results vary, studies suggest that providing electrical stimulation via a CI to the deaf ear can offer significant improvements in several key areas. It may restore some degree of sound localization ability, improve speech understanding, particularly in noisy environments, by providing a second input signal for the brain to compare, and often reduce tinnitus perception in the implanted ear. It aims to restore some semblance of binaural hearing, overcoming the core functional challenges of SSD in a way that Crossapec cannot. It's a really promising application.
That is fascinating, potentially restoring binaural benefits. Beyond hearing aids and implants, are there other helpful technologies, especially for specific situations?
Yes. The source mentions assistive listening devices, ALDs. The fundamental principle behind most ALDs is to improve the signal-to-noise ratio by capturing the desired sound signal, like a speaker's voice, closer to the source and transmitting it directly to the listener's ear, minimizing the effects of distance, reverberation, and background noise. Examples include infrared systems, often used in theaters or for TV listening, FM transmission systems, commonly used in classrooms for children with hearing loss, where the teacher wears a microphone transmitter, and electromagnetic induction loop systems, audio loops installed in public places like churches or auditoriums that transmit a signal directly to compatible hearing aids equipped with a telecoil or T-coil. Modern hearing aids also increasingly incorporate direct Bluetooth connectivity, allowing streaming of audio from smartphones, computers, or dedicated microphones directly to the aids, effectively turning them into personal ALDs for phone calls, music, or specific listening situations. These technologies are all about delivering a clearer, cleaner signal directly to the listener, bypassing adverse room acoustics.
Makes sense. Now, for individuals with severe to profound SNHL, where conventional hearing aids just aren't providing enough benefit, cochlear implants become the primary treatment option.
Exactly. For individuals meeting specific audiological criteria, typically severe to profound SNHL bilaterally, with poor speech recognition scores even with well-fitted hearing aids, cochlear implants, CIs, are the standard of care and have revolutionized management. The source states that over 600,000 people worldwide had received CIs as of its writing, and that number is much higher now. CIs are remarkable neural prostheses. They work by completely bypassing the damaged or absent hair cells in the cochlea and converting sound energy into complex patterns of electrical pulses that directly stimulate the auditory nerve fibers within the cochlea. This is possible because, in most cases of profound SNHL, even when the hair cells are lost, a significant population of the auditory nerve fibers, spiral ganglion cells, remains viable and capable of responding to electrical stimulation.
How do they physically work? What are the components?
They consist of two main parts: external components worn by the user and internal components surgically implanted under the skin. The external components typically include a microphone to pick up sound, a speech processor, a small computer that analyzes the sound and converts it into a coded electrical signal strategy, and a transmitting coil headpiece that sits on the scalp over the internal device, held in place by magnets. The internal components include a receiver stimulator package implanted in the bone behind the ear, which receives the signal transmitted wirelessly through the skin from the external coil, and a delicate electrode array that is carefully inserted by a surgeon into the scala tympani chamber of the cochlea, lying close to the auditory nerve fibers. The source refers to Fig 34-4, showing this arrangement. The speech processor determines which electrodes along the array to stimulate, how strongly, and in what temporal pattern, based on the incoming sound's frequency and intensity characteristics, attempting to mimic the natural tonotopic organization of the cochlea.
And the outcomes. What can someone expect after getting a cochlear implant?
Outcomes vary significantly between individuals depending on factors like duration of deafness, age at implantation, nerve survival, etc. But overall, they're generally very good and life-changing for many. At a minimum, CIs provide the experience and sensation of sound, which greatly aids with lip reading and environmental sound awareness. Most recipients achieve some level of open-set word recognition, understanding speech without visual cues. CIs also help individuals monitor and modulate the loudness and quality of their own voice. The source notes that within 3 to 6 months of activation and programming, mapping, many postlingually deafened adults, those who lost hearing after learning language, can understand a significant amount of speech without visual cues, and current state-of-the-art multi-channel CIs allow approximately 75% of these recipients to converse effectively on the telephone. What's truly fascinating here, biologically, is the brain's remarkable plasticity, its ability to adapt and learn to interpret this novel pattern of electrical stimulation, delivered by the implant as meaningful sound and eventually speech. It's not natural sound, but the brain learns to make sense of it.
That's incredible adaptation. Are bilateral implants, one in each ear, common now?
Yes. Bilateral cochlear implantation is increasingly common, especially as the standard of care for children born deaf, but also more frequently offered to adults. Implanting both ears provides significant advantages over a single implant, primarily related to restoring binaural hearing benefits. These include improved ability to understand speech in noisy background environments due to binaural squelch and summation effects, markedly better sound localization ability, and often reduced listening fatigue.
What about those hybrid cochlear implants mentioned in the source? Who are they for?
Hybrid CIs, also sometimes called electric acoustic stimulation, or EAS devices, represent a really tailored solution designed for a specific group of individuals who have a particular pattern of hearing loss. Typically, good or usable hearing in the low frequencies, but severe to profound SNHL in the high frequencies. For these patients, conventional hearing aids might not provide enough high-frequency amplification for clarity, but a traditional full-length CI might destroy their valuable residual low-frequency hearing during insertion. Hybrid CIs address this by using a shorter, more flexible electrode array that is inserted less deeply into the cochlea, using atraumatic surgical techniques specifically designed to preserve the existing low-frequency hearing structures at the apex of the cochlea.
So it's a combination approach within the same ear. Natural hearing for lows, electrical stimulation for highs.
Exactly. The patient wears an external device that functions as both a hearing aid, amplifying the low frequencies acoustically, and a cochlear implant processor, providing electrical stimulation for the high frequencies via the short electrode. This approach is particularly relevant for some patients with steeply sloping presbycusis or certain types of NIHL who fit this ski slope audiogram profile. They hear low vowels okay, but miss high-frequency consonants critical for speech clarity. The course indicates that outcomes for appropriately selected candidates show significantly better speech discrimination, especially in noise, compared to using either hearing aids or conventional CIs alone. It's a great example of personalized hearing technology.
That's really clever targeting. And for the absolute most severe cases where even the cochlea or auditory nerve is completely absent or destroyed, is there anything beyond a CI?
For that very challenging group of individuals, for example, those born without a cochlea or auditory nerve, or those who have had both auditory nerves destroyed by trauma or bilateral tumors, like an NF2, a brainstem auditory implant, ABI, is sometimes an option. Instead of stimulating the auditory nerve within the cochlea, the ABI electrode array is placed directly on or near the cochlear nucleus complex in the brainstem, the first relay station where the auditory nerve fibers terminate. However, the source notes that while ABIs can provide valuable sound awareness and detection of environmental sounds, the ability to achieve open-set speech understanding with current ABI technology remains quite limited compared to the outcomes typically achieved with cochlear implants. It highlights the significant challenge of effectively interfacing with the more complex neural structures of the brainstem compared to the auditory nerve.
Right. Bypassing the nerve itself is a huge hurdle. Okay, we briefly touched on tinnitus management strategies earlier, masking, hearing aids, coping. Are there any other key aspects the source mentions?
Beyond the specific management techniques like lifestyle changes, minimizing caffeine intakes, reducing stress, using masking sounds, background music, white noise, hearing aids, which often suppress tinnitus perception by amplifying ambient sounds, and dedicated tinnitus maskers or sound generators, the source reiterates a crucial functional point. Severe tinnitus can significantly interfere with communication by degrading speech comprehension, acting much like intrusive background noise that makes it harder to focus on and understand speech. And while there's no magic bullet cure for the tinnitus itself, approaches aimed at helping patients cope and habituate are important. Although not detailed heavily in this section of the source, therapies like tinnitus retraining therapy, TRT, and cognitive behavioral therapy, CBT, are often employed to help patients manage their reaction to the tinnitus and reduce the distress and functional impact it has on their lives. Antidepressants may also play a role in managing the associated mood disturbances.
That makes sense. Manage the impact if you can't eliminate the source. Finally, the source discusses practical communication strategies. These seem critically important for everyday life for both the person with hearing loss and their family and friends.
They're fundamentally important for maximizing communication success and minimizing frustration on both sides. The source highlights several simple but effective strategies. First, reduce environmental noise whenever possible. Turn off the TV or radio during conversations. Choose quieter locations for important discussions. Improving the signal-to-noise ratio is paramount. Second, utilize visual cues. Encourage lip reading, speech reading, by ensuring the listener can clearly see the speaker's face, which should be well illuminated. Avoid covering your mouth or turning away while speaking. Third, when speaking to someone with hearing loss, use a clear, slightly louder voice, but speak at a natural pace and don't exaggerate mouth movements. Importantly, be aware of the phenomenon of recruitment common in SNHL, especially in the elderly, where sounds can quickly become uncomfortably loud. Shouting is usually counterproductive and can distort the sound. Find a comfortable volume. Rephrasing, rather than just repeating the same misunderstood words, can also be helpful. And lastly, the source makes a simple but profoundly important point. Optimal communication requires obtaining the listener's full, undivided attention before starting to speak, and maintaining mutual attention throughout the conversation.
Why is that simple point about attention so crucial?
Because listening with a hearing impairment requires significantly more cognitive effort and concentration than normal hearing. The brain has to work harder to fill in missing information and filter out noise. By minimizing distractions and ensuring the listener is fully focused, you reduce that cognitive load and make successful comprehension much more likely. It's about creating the best possible conditions for communication to succeed.
That really resonates. Listening becomes active work, so making it easier for the listener by ensuring focus is absolutely key.
Precisely. It's a partnership.
Okay. We have journeyed through the incredible mechanics of normal hearing, explored the vast and varied landscape of hearing disorders, delved into the sophisticated diagnostic tools used by professionals, and reviewed the diverse range of treatment and management strategies, from surgery to advanced technologies to simple communication tips. We've really covered everything presented in this Deep Source chapter.
We have, indeed. We've aimed to go deep, pulling out the key details, the underlying principles, the clinical pearls, and the connections presented in this comprehensive chapter, really trying to give you that level of understanding needed to truly master this complex topic, just as you asked.
This deep dive was entirely tailored for you, our listener, working systematically through the material you provided. Hopefully, you now feel much more informed and equipped to understand the complexities of hearing disorders, perhaps approaching the level of insight someone working in the field might have.
And hopefully it also brings home just how vital our sense of hearing is, not just for basic communication, but for our cognitive health, our safety, our social connection, and our overall quality of life. And consequently, how important it is to protect it, particularly from preventable causes like excessive noise exposure.
Absolutely. As the source underscored in discussing presbycusis and its links to cognition and falls, and as our society ages, understanding and proactively addressing age-related hearing changes isn't just about hearing better in isolation. It's fundamentally about maintaining cognitive vitality, preventing downstream health complications, and staying connected to the world and the people around us for as long as possible.
It truly is a critical aspect of healthy aging. So having gone through this comprehensive deep dive together, exploring the intricacies of hearing and its disorders from mechanism to management, what aspects of hearing health, its assessment, or its protection might you, our listener, prioritize or think about differently now in your own life, or perhaps in discussions with family, friends, or healthcare providers?